Good morning, folks. We're just going to give everybody a couple more minutes to join. Good morning. As we're waiting for folks to join, I think, Brad, unless you would prefer that we do a quick round of hellos, I was thinking we could just have everybody put their name and organization in the chat since we've had several conversations already. Okay, great. Thanks. So as we're waiting for people to join, if you all could just put your name and organization in the chat for us, that would be fabulous. Great. Okay, Brad, are you comfortable with us, Brad or Fatmata, comfortable with us getting started?
I think so. Just again, from us, maybe a quick hello from DSS. Again, Brad Richards, Medical Director, Chief Medical Officer. Fatmata Williams and I are on the DSS front helping co-lead this. And just want to say thanks again for everyone's participation. Looking forward to talking with you further. We're still in the detailed design phase and look forward to kind of working through some of the details with you guys. And I'll turn it over. See if Fatmata, do you want to say anything before we pass it back to the Faulkner team?
No, Brad, thank you. Welcome, everyone. They can go ahead. Thank you.
Thank you, Brad and Fatmata. And for those who are just joining, good morning. Thank you all for coming. If you could just pop your name and organization in the chat rather than taking the time to go around the room today. We know we have an hour, so I would like to spend the bulk of the time having a conversation about health equity. So Tiffany, if you want to pop up the slides for us, thank you. So as I mentioned, we do have a shorter time frame for discussion today and a good bit of content to go through. And we have presented to this group in the past the framework for how health equity is considered in the design process around this maternity bundle project. But it's been a while since we've looked at it, and we wanted to revisit it as a group. Hopefully we sent it out to everybody on Friday, and hopefully folks had a chance to take a look at it and provide and have some commentary to provide. It's really this conversation is really intended to be truly that, a conversation about how the health equity pieces have been captured in relationship to each of the different design elements. So that's what we're going to spend the bulk of our conversation talking about today. And then we'll close out with a few next steps. So just as a kind of summary at a high level, you all received the framework from us on Friday and hopefully had a chance to look at it, but to just give a high level overview of what we're going to dive into. We broke the health equity framework out into kind of 4 categories, one being around design elements, the next being about community context, and then community engagement, and finally data analysis and measurement. And these are the different kind of elements included in consideration for the design. So it made sense to break them out that way when thinking about health equity. And just to go into a little bit more detail about each of them, and we've gone through this with folks before, but as a reminder, the overall goals of the project are around reducing reducing rates around NICU utilization, both overall and opioid-specific NAS rates, those adverse maternal outcome rates, and avoidable NTSB and overall C-section rates. And when we think about each of those different goals, we're looking at them as they relate to doula integration, where we've talked some about in this group about that already, looking at the infrastructure capacity building and improving access to doula care and folding that into the bundle. We've also talked some about the payment methodology and looking at how we're going to structure the payment methodologies to improve equity across the program outcomes, with a specific consideration for social determinants of health in risk adjustment methodology and reducing the avoidable C-sections. Additionally, looking at the building blocks as one of the elements of design, where we're looking to define the program parameters that are going to maximize the scope of program impact, such as inclusion of higher risk pregnancies and supporting parity between OBs and certified nurse midwives, which we've talked quite a bit about here. And then thinking about in the design element around the services to be included in the bundle, wanting to think about the services to create incentives that improve the quality of care, providing access to services that are not traditionally covered by Medicaid, which is really an important part of this bundle work around including doula services, community health workers. We've talked a lot about the idea of wanting to have breastfeeding support, and contraception counseling. And then finally, looking at what are the quality measures and prioritizing the metrics for provider accountability based on the impact on equity. So each of these design elements has been considered and through the lens of how can we best impact health equity across the board. For community context, we'll talk a little bit more about this momentarily, but really the focus is looking at mitigation strategies for understanding the community and how best to make sure that each specific population within different communities is being best addressed through the lens of health equity. And then community engagement is really kind of across the board. There are similar design elements, the first of which obviously is that this advisory committee that meets on a monthly basis and does include a few Husky Health members who have that lived birth experience. So bringing those voices to the table, as well as holding those smaller focused discussions, some of which we've had already, some of which we will plan to have as we continue through the design. And then finally, looking at the data analysis and measurement, there's quite a bit of work going on kind of behind the scenes a little bit right now to try and prepare to look at this, but a lot of the information that's feeding into those conversations has come from the discussions that this group has had, and the inputs that have been provided around the quality slate and process measures, methods for data tracking, reporting, and communication and metrics, and those conversations will continue with this group. So that's kind of a high-level health equity framework summary, and we're going to dive further into that document that we sent out to everybody, the PDF we sent out to everybody. But before we dive into that, we wanted to look at a couple of questions to keep in mind as we're looking at that document as a group. And these are the things we're hoping that the discussion today will bring around the considerations that may be missing. So you'll see that this is a draft document, and we're really looking for folks to provide thoughts around, is there anything that has been missed, or maybe does anything need to be kind of changed in the lens by which it's been identified so far? Additionally, are there additional barriers or challenges that patients may face? So we'll look at what we've identified as potential barriers or challenges, but by no means do we think that that's the exhaustive list, and are looking for thoughts from the group, as well as any barriers or challenges that members of the patient's care team may face. So not just the member themselves, but also the folks who are providing this care. What are the barriers and challenges that they may face? And then finally, looking at any suggestions that you all might have about additional mitigations to those barriers or challenges. We've done some work around identifying how best the DSS team can try and mitigate any of the challenges that are mentioned, but certainly look to the group for additional thoughts and feedback. So as we transition to looking at the actual PDF document, I'd take a pause for myself and ask for whether DSS team or Angela or Tiffany, if anybody has any additional context they'd like to provide. And then Tiffany, in the meantime, if you can pull up that document. Great, thanks. Okay, hearing silence, I can go ahead and dive right into this document. And before I before I dive too deeply into it, knowing again that we have kind of a short time frame, I'm not going to go through each of the specific cells on the spreadsheet here, but kind of at a higher level, and would welcome anybody jumping in at any point. Certainly, if you feel like you want to raise your hand, that's fine, and give any specific thoughts. Angela, I don't know if you have anything you wanted to add.
Yeah, no, I think that's right. At an earlier meeting, we had spent some time talking about the general overall column and gotten some of your initial feedback there. So are hoping that we can focus on how we carry that thread of equity through each of the design elements. And initially, we had thought about doing this conversation at the same time as we did each of the detailed design conversations, and realized that in doing it that way, it felt backwards or too late. And so really want to get out front of the overall design with a equity lens in a comprehensive manner, and are really hoping to use the rest of our time today engaging in discussion and getting your feedback on how to best integrate equity overall.
Great. Thank you. So with that, let's just start by looking again at the doula integration. I know we've talked, this is one of the areas that we definitely have talked about with this group in a little more detail than some of the other areas thus far. But as Angela said, we felt like looking at health equity by design element was making it a little bit more challenging than if we tried to go through the health equity in the design as an entire conversation at once, because there is a lot of crossover between each of the different design elements. And so it's important to see where there are similarities, but also really important to identify where there are some differences. So we may or may not have captured everything here. Certainly the expected outcomes of the doula integration is around wanting to improve those maternal outcomes and the rates as identified in that general column, with understanding in that second the second row there that the research does show that doula care is associated with positive maternal health outcomes, and providing opportunity for members of patients' community to provide the care. So knowing that the folks who people are most comfortable with are potentially the people they're going to go to early and maybe often. And then strengthening and increasing the racial and ethnic representation among current and future doula workforce. We know in this group, we've identified that the capacity that we have in the doula area it needs to be bolstered. And so this is an area where it feels like there's a lot of opportunity to really infuse the health equity lens. And I think as we scroll down, so that's really around the design element of doula, but as we scroll down and start to look at the community context, referencing back to what I was just saying before, there's a thought of a potential challenge here could be around the fact that there may be some doula deserts. In other words, areas where there just are not doulas available to help with certain populations who would really benefit by having the support of a doula. And the ability to ensure the availability of diverse doula workforce to meet members' needs is maybe a bit of a challenge too. And it's important to integrate the doulas into the maternal health care teams. That's one of the clear efforts of this work. But there could be some challenges around implementation of making that happen. And then finally, around the specific design elements that we've identified as mitigations. The group has really talked a lot about early investments in doula infrastructure to allow for that capacity building, including actionable steps resulting from analysis of those doula deserts. So, if we identify there are areas where there aren't doulas, what are the steps that could be planned ahead of time to be able to address and mitigate those issues? Also, the idea of early investments in increasing doula partnerships with OBs and midwives, and then developing any workflows and documented business processes that can be provided to practices to help them implement and engage with doulas. So I'll take a pause there. I didn't get through all of the doula column, but wanted to, before I give you too much information. Wanted to get some reactions from the group about any of the goals that we talked about and any of the challenges and mitigations. If there's anything folks have in mind that could be included. Karen, please.
One thing I didn't hear in that was design elements to ensure that the doula and the client are a good fit. That also can have an equity impact if we're not making assumptions about what someone's needs are, making sure that it's truly culturally appropriate care, culturally responsive care.
Yeah, that's great. And that was not captured there. Thank you. Other thoughts? Okay.
Lauren, has your hand up.
Oh, please. Yes, Lauren, thank you.
I just want to underscore, there was mention of the work that might be necessary to build the relationships and credibility of doulas with the OBGYN provider community. And I think that we really can't underestimate the effort that may involve.
Okay.
So, educating providers about what a doula is, what a doula does, how a doula can be helpful, and also doing some provider education around cultural competency. I think that's also a really important component to helping to move this along.
Absolutely. Yeah, thank you. Cynthia.
Good morning. I have the same concerns that were already brought up, so that's great. But also a very major concern would be, and it is briefly mentioned here, the challenges of making sure that there are enough doulas available. I would say that there's not nearly enough, and I don't think that we have talked more about having a plan to make sure that that can happen. I don't see the workforce really available for matching the needs of the community right now.
Yeah, I think that's a fair statement. I'm seeing folks from DSS kind of nodding their heads too. I think there's full agreement in that. And I think that there's definitely a need for that kind of the how to be a real focus of conversation in these groups going forward. Thank you. Dr. T.
Yeah, so I don't want to keep going over the same thing, but from the other side, and particularly when we've looked at the work that we've done with our peer breastfeeding teams, integrating the doulas into the practice. I don't know that a lot of docs have credibility issues with doulas. It's just that we don't have a set of doulas that we work with regularly, right? So every time a doula shows up in the delivery room, it tends to be a new person that we haven't had experience with. And so this concept that we bulleted here about integrating them into part of the care team, it's very interesting dynamic because you're working with a group of non-traditional care providers, and people are very reluctant to place that title onto community health workers and peer counselors and doulas, because I think they played a very important role in the community, and you don't want to strip that community part from who they are and what they do. But at the same time, we need to extend them into the care team and make them a reliable part of what we do every day, right? So I don't know exactly how you do that successfully, but as we've done the work with community health workers and peers here at St. Francis, it's a very tight walk to try to have them maintain their integrity as who they are and integrate them into a traditional care team, because they start to lose some of their community identity and some of their uniqueness. And I think we have to create almost a hybrid if we're going to be successful with somebody that my providers can say, I know you, I know what you do. You play an active role in advocating for your patient and supporting what we're trying to accomplish here. So welcome to my space, as opposed to it being an adversarial kind of situation that may be set up to fail.
Absolutely. Yeah, I think those all really salient points and really important, again, to say we can put a bullet on paper, but it's important to really think through how best to be able to implement that. Thank you. Tanya.
Yeah, I'm not sure if they went over my question. I think so, but basically, how would a pregnant female get in contact with the doula? How would they know that that's really an option out there? So, I guess going along with the doctor, he
Yeah.
said to get them to be a part of the hospital too, to be familiar with the 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 um the maternity wing, and as far as getting to know the staff at the hospital and to for the staff to know the doulas that are going to be coming in, there's a way for the insurance to say, hey,
Yeah.
this is an option, you know. I think I've said it in the beginning. No, I've said it. Oh, that's how I got on this board, was because a lot of mothers don't know the options that they have with the health insurance, with the Husky health insurance.
Yep.
A lot of mothers don't know that they can get a tummy band, that they can get rides, that they can get help. A lot of moms they don't know these things. And I think that once the insurance company comes across these sonograms or the x-rays for the baby, once they're doing that, they should definitely, it should raise a flag, and they should get a letter say, hey, we see that you are pregnant. We do have options, and we do have benefits that you can get in contact with. And then that's where the doulas would come in. Hey, if you want to try out a doula, or if you want to stay with your OB, that there's options out there, that the insurance is like, hey, if you are struggling with back pain, yeah, you can get a back brace. You can get a belly band for your stomach.
Yeah, absolutely. I think, and I think to where you started, you said maybe my question was answered. I don't think your question was answered because I don't think there's a clear answer quite yet. And I think that's a really important piece of the work that needs to be done here. So we talked before about the importance of educating the provider workforce, but it's equally as important to make sure that Medicaid members know that this is an opportunity for them, that to your point, Tanya, that these services are available to them. Is a critical piece, because obviously we can offer it all we want, but if people don't know that it's available to them, nobody's going to utilize it, and that kind of makes it not helpful. So I think it's super important to be able to address that. Thank you. Lucinda, I see your hand up.
Yes, and I think that Tanya and Dr. Tremblay kind of touched on this. It's not just about putting a doula, there's a whole system in place that needs to be changed, starting with the healthcare team, starting with the providers, understanding like what are those social and structural determinants of health, and educating themselves on that, educating themselves on what causes inequities, educating themselves on racism, and not so much looking as doulas as being, a fighting force, but looking at them as being welcomed, but also understanding how they can contribute to addressing these structural things. But a big part is going to play on these hospitals, these larger organizations, to kind of look at what's in place, because it's not working. So how can we change so that doulas can fit in the system, so that the woman is educated and knows her options? But I think that the woman should have the choice to choose her doula and be provided with some resources and what's available in her community. And then we could prevent the doulas who are working in the community from losing their reputation by keeping them separate from the hospitals. Because once you get into the hospital system, I'm telling you, those structures, especially racism, is a beast. So how do we get it so that we can kind of keep it separate, but still get the woman to have what she needs, to have safe care, to leave with what she needs?
Great. Thank you, Lucinda. And I apologize, my screen is not showing the full name, but Full Circle Doulas.
I think that those are great points. And I also want to jump off. It's important. The hospital near me has doulas. They have a doula team as part of their labor and delivery floor, but that they don't get the same care that they would with a doula that is part of the community, because you can't meet the doulas ahead of time. You don't necessarily know who's going to be on shift, if they're going to have somebody on call. And it's not the same. I don't feel like it's the same level of care. Also, because the hospital has its own doula team, they're slightly reluctant to work with outside doulas. They make you jump through so many hoops. And we're a certified organization, and it's still hard for us to get in to see clients. And I know COVID is a factor in some of this, but moving forward, it's hard. So
great, thank you. I mean, it's not great, but it's great to hear. I understand what you're saying in terms of it sounds like there's a, just when you go to the hospital and you're meeting a doula for the first time, that there's no relationship having been built there. I can see why that would be harder than having somebody who maybe you'd been working with leading up to it. So helpful. Fatmata, I see you've got your hand up.
Yes, thank you, Kristen. I just want to thank everyone for really these comments that they have made. And I just want to add that this is going to be very helpful as we move forward, because we do take the doula integration work very seriously. We do take the expansion of the workforce very seriously. The structures and systems that are in place that are already producing these bad outcomes, we take very seriously. So these are all discussion points that we will use to inform the doula integration work that we are currently trying to get afoot. And I'm sure that we will be updating this group when as we move closer to that. Brad, I don't know if you have anything you want to add.
Thanks, Fatmata, and definitely agree that I think a lot of the things that are brought today will be things that we need to monitor over time, and some things we have control over through DSS, and some things we don't necessarily have direct control over, but we can maybe influence. And I think those are important things, that a lot of these things are going to take organizational change and also practice change over time. And I think we're committed and recognize that to see improvements, especially in some of the inequitable outcomes, that this will take time and effort, and we are willing to put in some of that to help facilitate some of that change, but recognize it won't happen overnight. And we will be looking to all of you to help provide feedback, because we see this as an iterative process that, we're going to launch a maternity bundle with, the plan of having doula integration, recognizing it probably will be imperfect in terms of the design, and that we'll need to continue to monitor and hopefully improve it over time. And so we'll need all of you to help us to continue to do that. And so thank you again. As Fatmata said, just want to thank for the feedback and ongoing engagement, and we'll need that as we move forward.
Great, thank you both, and completely agree with Fatmata and Brad. That's a lot of really helpful content to be considered. So in the interest of time, let's take a look at the payment methodology. If we can go back up to the top here, Tiffany. And we have had some conversation around payment methodology as a group, but wanting to think about what are the expected outcomes of the idea around design here. And those are around improving equity across all program outcome measures, giving providers flexibility and tools to invest in the best approaches to achieve those outcomes in the way that works really best based on their populations, and looking at reducing those avoidable C-sections. Obviously, as we've talked about in this group, the idea here is not to say avoiding C-sections, period. It's really about avoiding C-sections where they're truly not necessary. And then looking at how does the proposed design element impact inequities. The focus here around structure payment model pricing in order to build in incentives for reducing those avoidable C-section, thinking about designing risk adjustment methodology to factor in social determinants that should improve the equity across all program outcome measures. Designing provider performance payment methodology in order to align clinical and financial incentives in order to achieve overall performance and quality metric improvements in aggregate and when stratified by race and ethnicity. And then finally here, the prospective payment for a subset of services included in order to facilitate the provider flexibility in investing in services like doulas and sufficient time in prenatal and postnatal visits. So thinking about where does it make sense to have the prospective payments versus the retroactive payments. And I think I do see that there's a hand up, but give me one sec. I just want to get through the next section of this and then we can dive into some feedback. In terms of the potential challenges when we think about payment methodology, we're talking about the looking at models that are provider centric and they're not necessarily transparent or easily accessible to patients. So that can be a bit of a challenge. Also, payment pricing challenges include only 2/3 of births covered under those 4 main global labor and delivery revenue codes. So there's a difference in C-section utilization, looking at a potential difference in C-section utilization by age. Risk adjustment methodologies are still relatively new, so to incorporating social determinants of health, so there may be some challenges or barriers there. And then the numbers by practice and provider, when we're looking at data in order to make some educated thoughts and decisions, they may be too small for meaningful stratification in certain cases. So some of the mitigation here was around ideas around further analysis, which is needed to inform the impact of births billed. This was something that came up, I think, in our last conversation. So births billed where the delivering provider is actually different than the postpartum provider. Also, again, looking at age adjustments, is there a way that we could break out the groups by age? Consider requiring patient notification that they will be part of the bundled project program. And so this, I think, speaks to, Tanya, a little bit what you were talking about, so that folks know that they're part of this program and what that means for their care and their provider's approach to the care. And having DSS to continuously review and monitor the impact of methodology on outcomes so that there can be adjustments made as the program progresses. And also investing in initial build needed for reporting to support the glide path to better ensure robust data collection. We know we've talked here before about the data is not all really, there isn't necessarily a lot of it, and it may not be broken up in the way that's most helpful to be able to identify things that are, how things are progressing. So wanting to make sure we're focused on that. So I will stop now, and Chris, please.
So thank you very much. I'm just going to ask a quick question that has been asked of me a lot and gets to everything you just discussed in a small question, which is what do we mean by avoidable cesarean sections and who adjudicates that? And I think that the reason that question's been asked of me is I don't think we're going to have, from our discussions on the last call, it doesn't seem like we're going to have that granular level data available. It seems like we really have overall cesarean section rate. And I think that alone is okay. We just need to lower the cesarean section rate. And I think attaching the word avoidable to it is very complicated for lots of different reasons. And so I just wanted to put that out there for people to think about. Sure. And as examples, if I have a patient who comes to my office and says, I want to deliver by cesarean section, I have trauma in my life, I want a cesarean section. Is that avoidable? Or for various different reasons around the labor process, a cesarean section is recommended. Is that avoidable? I just think that, and Lucinda's jumping in here too, around this concept of avoidable. Also, it's very complicated. You'll need a committee and everybody will be working very hard. I think we have access to our state's cesarean section rate. It seems like reliably so. It's not broken down by obstetricians, midwives, who is caring for the patient, induction of labor, gestational age, high risk, low risk, lots of different things. I think maybe we should just say cesarean section rate.
Fair. I don't know if the DSS, Dr. T, I see your hand, but I just wanted to see if the DSS team has any thoughts or response to that.
I was going to say if Dr. McGrath is on the call, maybe he can add a little bit, but I don't know if you want to say anything, but I was also thinking So we use avoidable, then there are times that we use unnecessary, and then we do NTSV. So Dr. Morowski, in your opinion, what about the NTSV rate? Should we still just look at the overall C-section? Because I heard on the call this morning, Dr. McGrath and CHN have a methodology, how they're able to actually isolate the NTSV C-section rate. So should we go that route? I just wanted to throw that out there. I'm not sure if Dr. McGrath is on this call, and maybe he may want to comment, but I also see Dr. hand up as well. Thanks.
I am Fatmata. And yeah, I mean, I think it's important to remember that what we're looking at here, the data will never be perfect, right? Without somebody doing a chart review and looking at all the clinical notes, and if the OB documented their conversation about why they chose a C-section. So I think this is all just going to be used directional. So I think that a committee of clinicians has to decide, do they want to use overall C-section rate? I think the NTSV C-section rate has probably become more of an industry standard in looking at this. And so early on, we did create a methodology for looking at the NTSV. It's out there, you can download it from different websites. So we didn't have to create it from scratch, but we were able to generate those rates. So, again, a group decision to be made based on what data we have and is available to us.
Okay, thank you, Dr. McGrath. I just wanted to throw one more thing in. So looking at the overall C-section rate, will that help the disparity? Because there is clear disparities in who gets C-section, and we have the data to show for that. So I'm just throwing that out there as well. But in the interest of time, Dr. T was next, and then it will be Representative Gilchrist. Thank you.
Yeah, I just wanted to kind of echo Chris Morowski's points, and I do think NTSV might be a little bit better, but for the last 2 years, I've been reviewing every case at St. Francis that is an NTSV section, and I see what we're putting here, and we use words like avoidable or NICU admissions. As a provider, when I'm looking at C-sections and I'm looking at NICU admissions, I don't want to incentivize away from those tools and technologies that we have available to us, because that could further the disparity for the patients that actually need that, right? If we're incentivizing those things. So just to put it out there, I know there's value in these metrics, and we're actively working on them at St. Francis, just like they are at UConn and Hartford and every place else. But I think it's important to make sure we're not going to incentivize poor care, because that will only be amplified in the actual folks that we're trying to change the course for here. Yes, there are more sections done, but I got to tell you, I'm looking at the strips, I'm looking at the cases in a blind way here at St. Francis, and those patients needed to go to section. They were in trouble and needed to go. I'll take those sections every day, and I'll count them up. And if we have the highest rate in the state, I'm okay with that, because I think they needed to go from a clinical standpoint. So I don't want to incentivize my providers away from good care for the patients that may need it the most.
Got it. Thank you. Representative Gilchrist, please.
Thank you. What is NTSV? What does that stand for?
Oh,
nulliparous, transverse, singleton, and vertex. It's normally, I'll leave it to the OBs to say, but it's normally the cases where it's really a C-section may not be needed, but I'll leave it to the OBs or people on the call too.
So the way I look at it is, a patient who is an NTSV patient arrives for her first delivery, and for all intents and purposes, we should expect her to deliver vaginally. And whatever happens, she goes to section. So we have an expectation of a vaginal delivery that results in a C-section. That's what the NTSV rate is. And so it's the place where you have the highest opportunity to take a patient and not commit her to future C-sections, because most patients, or a lot of patients, will accept a repeat cesarean instead of trying to have a vaginal birth after a cesarean. So it's our opportunity to keep that patient on the vaginal delivery track, if you will.
Thank you. And then this is my completely unscientific, but based on my own experience and in conversations I've had with women, I'm wondering, when we're looking at disparities, is there a way to back it up. And again, someone please tell me if there is a protocol, but it's my understanding once you are overdue, you need to get either stress tests, I don't know what they're called. And then if you go a certain amount of time, it is suggested that you get induced. And with the stress tests that are required, you have to take time out of work. And so the disparities, for someone who can't take all that time to be going in like every other day for the stress test, you might, and you're at the end of your pregnancy and you're just kind of done, like you would maybe do the induction and then again, unscientific, but it's more likely that you then would need the C-section. So is there any way for us to be able to like parse out that, like, is that part of the reason that there's higher C-section rates?
I'll have to defer to the, I don't know whether it's the DSS team or Dr. McGrath, I'm not sure.
We'll defer to the OBs on the call or NP, nurse practitioners.
Yeah, I think we don't, from claims data, at least now probably won't have that level of information that would be required to answer it in that specific way. And that's always going to be something, as of now, at least we're limited by. I think what overall we know C-section rates are probably higher than they should be. And there's downsides to doing excessive C-section rates. And obviously we want people, if they need a C-section, to be able to get a C-section. And I think that's, we're going to have to make decisions about what our outcome measures are, and is the overall C-section rate numbers, which is kind of what had presented previously, as well as NTSV rates as well, which also seem important. And we're going to have something in place. And ultimately, we want the best care for those who are delivering. And we want to provide some flexibility to providers to help figure out what that means. So, and I also include doulas in that as well, is, what is the need of the individual? How can we tailor it to that need? And hopefully over time, paying through a bundle and setting outcome measures such as overall C-section rate and NTSV rates, that we can drive towards that, acknowledging there's still going to be some imperfections in the system.
Yeah, I think it's important to remember, no one is suggesting the C-section rates should be 0, right? I think the assumption is we have a higher than average, for the state of Connecticut, higher than national average C-section rate. Medicaid is even higher. Are there unnecessary C-sections occurring in that population? And if so, what can we do to decrease those unnecessary C-sections that, if we all agree, are happening?
Yes, thank you, Dr. McGrath. And within the higher C-section rate, we also have the disparities as well that we have to look at.
Yeah.
Agreed.
Karen, sorry, you've been very patient.
Oh, I was just going to ask, it sounded to me from what you were saying as though you were not measuring the gap in C-section rates. So incentivizing a reduction in the disparity might target exactly what folks are talking about. So if you're incentivizing a reduction in the disparity, then you're looking for what are the root causes of this? How do we address the systemic racism that contributes to this, right? As opposed to just reducing the overall rate, which is more likely to, initially at least help the folks who are already more privileged in the system.
Yeah, and we definitely, and I think are wanting to do, and when I say overall rate, I actually mean the rate that's stratified by race, ethnicity. That is definitely kind of our goal, is to call that out. I just mean, and I should have been more clear that, like, avoidable versus, that we make, as of now, I think looking at what's our race, ethnicity data for not just C-section, I think Lucinda Canty highlighted that, obviously, and I think based on our last conversation, that's one measure. It's not the only measure. We're really worried about, what's the experience of our members, what are people getting access to doula support, breastfeeding support. There's lots of things that we ultimately want to see, including reducing adverse maternal events, which are obviously also really, really important, and decrease NICU utilization when it's not needed or when we think it can be avoided by hopefully doing things further upstream. But I think the point that you're making, Karen, is like we need to be making sure that we're, as much as we can, stratifying things by race, ethnicity, so that we're not exacerbating or maintaining disparities and inequities, and we try to drive those down over time, which definitely is one of the main goals here.
Well, right. And if we're talking specifically about payment methodology, just making sure that that is part of the incentive is the reduction in disparities, not just a universal approach.
That's definitely something we're like to do. I think one of our challenges is making sure we have accurate data and we have big enough N size to be able to do it. Though I think that is a goal to be able to do at the provider level. It's just practically, can we do it reliably? And that's still something we have to work out, but agree that ideally we would be able to do that. But if you only have, if you're a provider and you have 5 patients, 5 members that are Husky, doing race ethnicity stratification could be challenging on a year over year. So there's some technical details we need to work out, but I think overarching goals we agree on.
Great. Representative Gilchrist.
Thank you. Do providers track induction rates? And can we track that?
Providers
have not been able to track that on claims data. So again, we're at the point of having to do a chart review.
Great.
Yeah, I'll just jump in real quick to say, Representative Gilchrist, you're asking the great granular level detailed questions that I think we'd all want to ask ourselves. And the answer to post-term pregnancy, cesarean section rates, inductions versus spontaneous labor, gestational age, all these various complicated things that go into a cesarean section rate are so important. They're not actually in clinical research, not yet completely decided. And I don't think we'll have access to this, everybody, right? I think that's the point. I don't think we are going to at any point have access to this granular level of information. And that's why I just recommend against these adjectives or adverbs of unnecessary or avoidable or things like that. And if we just stick with the word cesarean section rate, and however we define that, I think will be better received, more accurate, and is I think as granular level as we're going to be able to get anyway.
Thank you. Dr. Schaefer. Oh, you're on mute, I think.
Good afternoon. Thank you. I have a question, actually one bullet down from avoidable C-sections or simply C-sections, and that has to do with design risk adjustment methodology to factor in social determinants that should improve equity across all program outcome measures. I'm interested in how you will decide whether and when to incorporate social determinant-based risk adjustment, since on the one hand, by adjusting for social determinants, you're essentially controlling for social determinant risks, and that can be good in terms of helping to ensure that nobody's doing isn't deciding which patients to take on the basis of the social determinant risks they have. On the other hand, it can mask disparities by controlling for food insecurity, housing instability, interpersonal violence.
I don't think we've quite figured out how we are going to be able to do it as of yet. And hopefully we will be able to just kind of bring that back in this next design phase. So there's some obvious, and I think, as you know, well, Mark, there's some challenges with doing it. And so that's to be determined. I'm sure you guys are familiar with, or some of you may be familiar with that, CMS is trying to do this utilizing ADI, which is not at the individual level exactly, but it's taking individuals where they live, area deprivation index, and applying it in one of their new models is definitely something we will be looking at, but I don't think we're definitely not ready to commit to whether we can do it. And if we did commit to do it, how we would do it. Angela, do you want any color to that or specificity?
I agree with what you just described. Other Medicaid programs have been able to incorporate this in varying ways, and it seems important to be able to figure out how in order to adequately establish a budget for the bundle that enables providers to be able to support social determinants.
So I'll just have a comment and then on that, and that is, even if you can control for area, say for SDOH using an area deprivation index or something like that, the question in my mind is, should we? And I guess I've raised for consideration by the payment reform group, where I assume you'll dig deeper into this, is whether you would adjust for something, the SDOH, through something like an ADI in order to ensure that for quality comparisons, you're not disadvantaged by having patients who are disproportionately from ADIs, but at the same time, that becomes a variable on which you actually stratify to look at disparities. So it would seem to me it's a goal that for people who experience housing instability or food insecurity, interpersonal violence, that the ideal might be to get to especially where you're using tools like doulas and during the prenatal period, that you would aspire to be able to make food insecurity or housing instability less consequential, or something you solve for in a way that optimizes maternal health outcomes, maternal child health outcomes. Thanks.
Thank you. So we do have a few minutes. I'd like to just do what we can to go over a little bit of the building blocks around the bundle. And I think we've actually touched on this through some of the conversation already, but helpful for the group to just see here what we're talking about when we think about what the expected results and outcomes would be. It's really about the building blocks defining the bundle program parameters by defining the episode, period, accountable entity, and patient population, with the expected result of maximizing scope of the program impact. So obviously we want to do the most we can with the way that the program is designed, and supporting parity between OBs and certified nurse midwives. So the target reductions in racial disparities and adverse maternal and infant health outcomes, the plan is to hopefully do that through episode definition, which is really about considering the possibility of extending postpartum period from 60 days to a year, among other potential considerations. For the patient population, it's looking at including higher risk pregnancies, which are typically excluded from bundle programs. And for accountable entities, it's looking at requiring provider participation to ensure that all Husky Health members receive care through a bundle program. And as we look at the community context, thinking about the high-risk pregnancies and balancing the care of high-risk and cost pregnancy episodes with provider concern over the ability to impact the risk exposure for those things that are beyond their control. Obviously, that needs to be considered. And then there's the diversity and cultural competency among provider workforce. So we talked a little bit about this before. Somebody alluded to the idea of making sure that the workforce really understands and has the proper training to understand the populations. Upstream factors beyond the DSS control, such as limited ability to impact inequitable social determinants of health on the community and early access of prenatal care, which has obviously been linked to more positive health outcomes. And then participation of provider types where base payment model is different, such as the FQHCs and hospitals. So taking those things into consideration. Those are some of the kind of challenges that folks have been identified. And then for some of the mitigations for those challenges, the things that have been talked about are the inclusion of high-risk pregnancies and the need for DSS to do some evaluation of the use of a financial proxy in order to balance the higher risk pregnancies, such as those with substance use disorder, then with provider protection from risk exposure for those things that are beyond their control. And for the diversity and cultural competency, DSS is exploring the use of structural measures that can support equity, such as training, the inclusion of access to community-based supports like doulas and CHWs, and also strengthening a workforce that's reflective of the community being served. So the kind of a combination of the education and also incorporating folks who really understand the community they're in. And the community they're supporting, and then upstream factors beyond the DS control that look at evaluating the performance stratified by social risk scores, in addition to the clinical risk scores, and provide a reporting on care coordination services in order to support members' non-medical needs. So we do have a few minutes left. Would love to hear thoughts and reactions to what's been captured so far when we're talking about the considerations for building the blocks for the bundle. Perhaps we got them all. Maybe not. Dr. Morosky, please.
It's the word no other. Can't have silence. Along with the word avoidable being difficult to define, the high-risk pregnancy is difficult to define, just to put that out there. There's no, I'll have everybody kind of in their minds understand the concept of preterm birth and low birth weight. We know those numbers. They are defined. It's 36 and 6 and under for preterm birth and low birth weight under 2,500 grams. So we know these numbers. Avoidable, again, we talked about that a little bit, thank you. And then high-risk pregnancies. If a patient is 36 years old and the healthiest person I've ever met in my life is the fact that she's 36 years old, make her a high-risk pregnancy because she's advanced maternal age. That's a conversation I have a lot nowadays. And then there's a range of high-risk pregnancies. Some patients are very complex and have a risk of mortality in their pregnancy because of complications of the heart and their lungs or brain or something like that. So the range of high risk is broad. And again, how we define that, who adjudicates that, how we think about putting some type of number on that, I think will be complicated.
That's helpful and certainly consideration. I agreed, it's hard to define these things if they're not already defined. I don't know if the DSS team or Angela have any thoughts.
Well, it's Dr. T. If I could just take that one step further, it's very clear that the data also suggests that we should be applying high-risk pregnancy to the things that we've been talking about. The social determinants can create a high-risk pregnancy, and that's not even in the traditional lexicon. Dr. Morosky just gave you the litany of things that we learn about in the textbooks that put us on notice that this mom may have problems in the pregnancy, but it's pretty clear to me after practicing for 20 years in downtown Hartford that just living in downtown Hartford can make your pregnancy high risk. It's exactly why we're looking at these maternity bundles. So, creating opportunities for patients to receive upstream services that are going to allow them to be better self-advocates, and thinking about the things that are going to allow us to take better care of these patients that are identified with these high-risk conditions that we could actually impact, like whether or not there's food on their table, seem to be things that we're talking around here that we need to get right at. We should be thinking about these things as high-risk situations, and to me, it seems most that we failed in giving a lot of our patients in some of these scenarios an opportunity to self-advocate in a meaningful way. And what we're trying to do is put those resources at their fingertips or make them available to them. And so to that end, whatever it takes, but we really should get at those things here. We have a great opportunity here to get at that and to really start working for it. So, for what that's worth.
And I'll just add, in terms of, definition of high risk, I would agree. And the reason we're even calling it out is in a lot of bundles, those risk factors that are often deemed high risk are excluded from the bundle. So if individual has a high risk condition or often sort of significant and persistent mental illness, they may be excluded from the bundle and not gain. And so I agree, there's not maybe a good definition, but what our goal is trying to say is we want to be as inclusive of those conditions as possible, so that those individuals that are what may be traditionally deemed higher risk for different types of outcomes that we might say are costly or less desirable get included, so they can hopefully get the benefit of these services. Potentially, we obviously want to allow providers to have more flexibility in the care that they provide, obviously holding to a high standard and outcomes focused, including, in the long run, member experience that would allow for members to, maybe do more with identifying community resources for that might help address issues with food insecurity or housing insecurity, acknowledging that providers will be limited in some of the things they can do, but there can be more encouragement to both understand and identify them, which I think we know is something necessary. And I know we're at time, so my apologies for going on, but.
No problem. So Lucinda, I see you have your hand up. Before we jump to you, let me just say for those folks, I know there are probably some folks who have to drop off. If you have more that you wanted to share, please feel free to email us with that. We really, really welcome the feedback and would like to try and incorporate everything that we can into the design. So I apologize if we didn't get to everything. So for those who need to drop off, please do. But Lucinda, please.
Yeah, I just want to say something really quickly, because, and I just thought of this, is that being a Black woman, a Black birthing person, places you at high risk in this country, in this state. So I feel like we have a lot of metrics, but I feel like sometimes it blames, even if we're looking at social determinants of health, we have to be careful not to blame the woman for her outcomes, because there's a system in place that is placing her at risk. There's, in my healthcare encounter with my provider, there are things that are happening that place me at risk. So how do we capture that? Because I feel like Dr. Trumbull, I think you just said, this is an opportunity. This is an opportunity to empower those that we provide care to, but to also identify, name those things that unnecessarily place women at risk, place birthing people at risk. So how do we get there? How do we understand, there are social determinants of health. And we know that we can have a patient that lives in poverty that's 16 years old and not have a cesarean, and not be considered high risk and have a healthy baby. So so there's other things in that system, because the other side, you could be Serena Williams and you could almost die. Luckily somebody listened to her. But how many people did she have to say she had chest pain before something was done? So I think that we have some metrics here that could be measured, but I think that we also have to look at those things that we don't like to look at that are scary. So we really have to think about that, I think, as well. Because I see the language, but I think it could still skip over those things that are on a provider level that could be improved, on the patient level that could be improved, on the hospital level that could be improved, but it's going to require us to look at those structures in these systems that say they provide good health care. So I just wanted to just throw that out, is how do we do it in a way that the woman is not blamed, I just think this is an opportunity, as painful as it may be, to do change. So I just want to say that. I know it's complex. It'll take time to get there, but I just want, as we're moving forward, to think about that.
Thank you, Lucinda. I think that's really, really important. And also, to your point, I think it's a challenge to put on paper how do you get there? So sometimes people aren't able to focus on it because of that. But I think it's incredibly important. So I appreciate those of you who were able to stay on a little bit longer. I think it was totally worth the extra minutes to have that conversation. And thank you all for your time. Just for next steps, we will incorporate anything that we've gathered today, and certainly anything that you all want to send to us down the road into this effort. So please don't hesitate to reach out to us with other thoughts and considerations. Thank you all very much for your time. Have a great day.